Thank you, thank you. The only thing I want to say is, if I were to just, if you think about something about myself, is that I am passionate about public health and Hispanic health, and this is my heart and my soul. I came to this country to work a little further on my doctoral degree. I'm from Mexico City, to try to learn a little bit more so I can give back for my community. So I always try to do that in different ways, and I hope that this project brings a little bit about some of the things that I've been doing. I think what I'd like to present today is two things. One thing is to provide, I think, a contextual environment of how do we apply really models of the community. So I want to tell you a little bit about the community health worker promotores de salud model. So this is going to be really a little bit different. It's going to be really in trying to understand why we need community outreach models and what does it take to really work with communities. Because as always I think about it, working with communities is an art and it's a science, and we have to work with communities with respect and dignity, with science, but with many, many things. And so I want to just tell you a little bit about that piece. And then I want to tell you a little bit about, to illustrate how working promotoras de salud have been working in delivering risk reduction for cardiovascular disease. A lot of the exciting things is that, that some of the areas that we have are similar to Dr. McCormick's area, so I think it's exciting to see that we have similar interest in ways that we are developing some of these ideas. So what is it really the cultural milieu and conceptual frameworks? What are the things that we have to really understand to look at this? So we already looked at this. So we know that this is really a very exciting time because many foreign women from Mexico are part of the percentage of total population in the US. This is a tremendous demographic change that we have seen, that we have talked about it. So I'm not going to dwell a lot about this because we know this is a very interesting demographic context. We know about health insurance, so I'm not going to tell you a little bit about that. Dr. Andres presented this work on that we have tremendous problems with lack of health insurance in El Paso, and so this is the same data that Dr. Andres presented. Overweight and obesity, the same thing that you guys have seen, so I'm not going to dwell upon it. Diabetes, Dr. McCormick mentioned a very exciting work on diabetes, so that's already taken care. But one of the things that is really critical, when we think about contextual factors, I always want to think about that there are going to be a lot of things. Sometimes it's social and family fragmentation. Sometimes it might be individual decision-making when we think about behaviors. Sometimes it's a lot of socioeconomic, as we have seen, the strong relationship between poverty and education. Sometimes it's about structural barriers, and sometimes it's about the black box that we really don't know, really what it is. I mean, sometimes we really don't know what happens. So I think that black box is important to recognize. So what is that conceptual framework that I think is required to see the synergism between the environment for cardiovascular disease prevention and control? Well, a lot of the times we have really concentrate on what we think is the medical model. In looking at the medical model, it's going to really provide the opportunity for prevention. But we know that that medical model is very limited in the capacity for primary prevention and secondary prevention. And so we need to really expand to the public health model, the educational model, and so many other things. So what do we want to do that? And how can we do that? Well, one of the things that we need to do is attach new concepts. And that attachment means outreach. We really have to begin to start attaching to these models of medicine outreach programs. And we have to begin to start thinking about, as Dr. McCormick mentioned, environmentally restructuring, as Dr. Stockles mentioned about these ideas of restructuring our environment. Well, we have to do that in different contexts, not only in the individual context, which sometimes we have seen the medical model intersect with the family, although it has been difficult for the medical model to provide us answers with that, and then we have to intersect with the community model. So, for doing that, we have to really begin to start looking at these outreach components, and that in itself is a science, to really how to understand the restructuring and how do we go about working in communities when we are really committed to expand to the community public health model. So why is this a paradigm? Well, it's a paradigm because of the fact that we have, in many ways, a failing healthcare system that sometimes doesn't reach too many people. We also how to think of the need for best practices that are built in community, focus in mind. What are some of the practices that you have heard a little bit before that are really important in communities? So we need to also look at new paradigms of sustainability and legitimacy so that we can begin to stay in communities and not just come in and out, collect data and leave. And so I think it's wonderful to see how a program has collected data but staying there and trying to change Brownsville in a different way. So that is really laudable because of the fact that we need to look about sustainability and legitimacy. So we have been working on trying to, in a very humble way, understand the outreach concepts and how to really we understand these concepts. And we believe that the community health worker model is a positive way of integrating some of these systems. It's not the only way. It is a positive way to start thinking about community systems in some way. So, as we saw before, this is the same thing. You've seen it in terms of the synergy, but what is kind of interesting in this case is that we are incorporating in the synergy the promotora model. So that's really the only difference here, where you see the individual, the family, the community, and the society. These are all, as we all have talked about, contextual ecological models. And so we need, for many conditions, a contextual ecological model. But I think what is important is to begin to insert community-based experiences that can give us an idea of how to link some of these models. So the idea then begins to be in the context of this synergism, where we believe that there could be a brokerage in communities, that communities can serve as brokerage between somehow the medical model. So we don't abandon the medical model because we need diagnosis and we need all kinds of things. We need data collection. We need all kinds of important components of the medical model. However, we do need to expand and to broker with communities. We need to begin to start looking at the community environment. And what is kind of interesting is that brokerage is something that we have put less attention about what is the science of brokerage. How do we really begin to look? Now the word is community-based participatory research, health disparities, reduction, but in reality we have to really anchor some of these words to begin to start really looking at how we are going to begin to work with communities with dignity, with a lot of impetus for bringing out best practices, and begin to start linking individuals, families, and communities in some way. So we have some synergism as this important paradigm. So we know that the promotoras model is a good broker. We have beginning to look at exciting evidence that more and more and more comes in. This month just came up, I think, a promotora model for a controlled randomized diabetes trial. So there's been already more and more evidence that comes about the important brokerage system and how it can affect different levels of the medical and prevention agenda, the reduction of visits, the decreasing complications, and some of this are beginning to see. However, somebody will say, well, I just looked at, I remember a randomized meta-analysis that was done with, or sort of like meta-analysis with Promotoras de Salud, and somehow that the evidence is not as strong as we think. Yes, that's true. It's not as strong, but there's a lot of things that are very important in community brokerage that we really need to learn. So we need to really combine some of these elements of good science with good community brokerage. And I think that's something that we need to learn how to do it. So building synergy for community in looking at this promotora model means that perhaps we can look at this kind of a model that we just have presented in health promotion practice in 2006, when we begin to start looking about to the left side some issues of this ecological perspective and building up this CBPR process where you engage people in the communities and people that come in from different organizations. So you can also use social action theory and begin to start thinking of empowerment methodology like Paulo Freire, and begin to really start thinking that you really need to start engaging in empowerment methodologies to start building up that ecological perspective that makes sense, that really is going to actually utilize some behavioral theory. But as I mentioned in the black box, the behavioral theories as Reznikov, Dr. Reznikov mentioned from Michigan, we cannot just necessarily think that, because chaotic theory is something that we really need to start looking at. And we believe that sometimes we need to start looking at many different elements of theories that can be incorporated. And so I think sometimes it's humbling to say that sometimes we don't know what happens in our individuals, because it's very chaotic sometimes the way that we actually end up doing. So maybe cognitive behavioral theories or behavioral elements of looking at the patients and how to engage are interesting ways to start thinking how chaotic the system is. So then you begin to start building some infrastructure, as we move to your right, into partnership development. I mean, we want to develop, in the real best world, every single person is going to have healthcare. Every single individual is going to have the capacity to have a family. Every single individual is going to have all their needs met, but that doesn't exist yet, right? So we need to really start looking about ways to build. And also the government is not the only one that's going to do it, but it's going to do a combination. We have to have all kinds of policy that come from social justice policies that go directly to different programs that are integrated in communities. So, but we need to get some help, provide some support to the model of building development and partnerships. And we also then have to really, if we want to broker the community, we have to learn about cultural dimensions of communities. We have to really understand what do I mean by culture. And I think Dr. Ross mentioned very clearly, some things are not necessarily the Hispanic, but it's issues about many other things that may be cultural, may be not cultural. So we need to start thinking about some of these dimensions, and then we need to start thinking about building some methodology that anchorage or anchor the promotora model, train-the-trainer models that we can begin to start incorporating into the project, so that we can begin to finally start thinking about Hispanic family cardiovascular health promotion, risk reduction, so that we can begin to control our diabetes, control our obesities, control our hypertensions, and begin to have more fruits and vegetables, and live perhaps, as people say, a better life according to what they think is better life for them. Which sometimes we don't know exactly what it is. As a couple of colleagues, Dr. Buchanan mentioned of what is to really the kinds of indicators that we need to get for understanding what is well-being. But anyway, so we got done a couple of promotora models, which is based on a program which is called Salud para su Corazón model. So since 1994, the National Heart and Lung Institute of NIH, the area of research, prevention, and control, they have the least money. A lot of the money is from the NHLBI Research Corps. This one has less money, but however, they've done a really nice job in bringing up developing of prevention of materials. So we have incorporated since the beginning that idea of working with some of these models of promotoras, utilizing the Salud para su Corazón program. So we have worked with developing what we say the Salud para su Corazón National Council of La Raza program. And we published in Preventing Chronic Disease and Health Promotion Practice that experience, where we work with the community-based organizations. Then we work with another model, which was the Salud para su Corazón North Texas model, where we work with the Enhanced Dissemination and Utilization Centers that was supported by NHLBI, that Office of Prevention Education, where we develop a community university partnership to recruit people from the community, and we started from scratch. We didn't have any promotoras, and we started from scratch to develop the promotora in the community. So that was that model that we worked, and this was published also recently, American Journal of Health Education. Then we worked with other models that has been intersecting the Salud para su Corazón model with the medical model, that's with the Health Research and Service Administration, to try to integrate the clinical model with the community model. And I'm going to show you a little bit of that. That is data that just got published in Preventing Chronic Disease. And I would tell you a little bit about that. We have done some of the other models with hypertension control. We just finished one and created a fotonovela that is available in the CDC prevention. You can take a look at that fotonovela. And it was the prevention of high blood pressure. So I'm not going to talk about that one. But I'm going to talk about the one that we have a collaboration here, which is with the University of Texas, El Paso, my colleagues from El Paso, and us, that we have developed a program that in many ways is a similar program that Dr. that they're doing in Brownsville with Dr. McCormick. Sorry, I need to get a little water. All right, so this is, so I'm going to tell you a little bit about these projects very briefly. I think the first important point that I'm going to tell you is how do we develop the kinds of community brokerage that we think is important. Well, in every single project, there were some common elements. People from the community. This is from Centro San Vicente, Esperanza, Yodelinda. We have our college from Centro San Vicente right behind us, right there. Please say hi right there. Yes, our college, Promotores de Salud, who have been very engaged in these programs for many, many years. So we always put the process of planning, implementation, and evaluation. So they go through a very exciting process of looking at what is the needs, how to develop the goals, how to look over a model, how to plan the evaluation, how to implement, how to begin to do the training of promotoras, how to begin to start thinking of the curriculum that we're going to use, what are the monitoring of the programs, and then how do we include community activities, and then how we evaluate all these processes. So how do we really integrate some of these elements of culturally relevant interventions applied to low-income, low-acculturated Mexican Americans? Well, we think that when we started in 1994 working with the National Harlem Lung Institute and began to work with communities and NCLR and all these communities, we began to think that we needed to look for programs that were culturally competent. So the Salud para su Corazón program was born in 1994 as that engine of materials that NHLBI was very interested in making culturally competent the materials. So there was a program developed, and a lot of materials were developed at that time to test the materials, to take time to work with communities, to develop a whole set of different strategies that incorporated building alliances and developing all these interesting methodologies for looking at how to best develop materials. So, and also we discuss a lot of the pedagogies of empowerment. We think about that we needed to think of mobilization of people in social system. It has to be a synergy, that we really need synergy, that we really need to really be constantly in communities synergizing, giving them the opportunity to start building that farmer's market, to building that kind of a structure that Dr. McCormick was mentioned, but that doesn't happen in isolation. Has to be with these methodologies of moving people to the same common goal. So we thought that that was important in all the projects to infuse. We also had one premise that was really very important, that working with communities is an art, that we have to enter communities and work with them at their own pace, using community-based actions, but we have to really think about culture with dignity and think about learn how to work on their own pace. And that is using their own capabilities. And this is really a challenge, because working in their own pace with their own capabilities, being sort of like dignified in terms of how do we want to approach them is very, very challenging. But I think it's important that we have to learn how to do that, because that can help us to try to frame the activities that we want for sustainability. So we selected a community-driven model for all the programs, whereby we were going to begin to guide a cultural agenda that was going to be something difficult to measure, but that we were going to build it up in terms of different steps. And I'm going to show you what are some of these cultural steps that we integrated into the programs. We thought that the philosophy of prevention, we decided to pursue a community-based approach to start with. We didn't start with the gold model as a randomized clinical trial. We knew that that was going to be very difficult to approach. If we really wanted to start working with communities, we needed simple sample projects, simple pre-post comparisons, even though we knew that this was not necessarily the randomized. And some people have claimed whether that is really the best way to go about. And we can debate that for a whole afternoon to see whether that's the only way that we should go. There are many important ways to do a community base with randomization, with control, but I think sometimes in the sequence of moving towards communities, there is a pace. So we decided that to follow that pace, and we ultimately end up doing a randomization that I'm going to show you. And we framed the cultural approach in contextualizing ethnicity, as again Dr. Rose mentioned, it takes many dimensions and many inputs. So difficult to say what is the Hispanic when I'm a Hispanic, and so it's really very difficult. A lot of people don't really think me as a Hispanic. Are you Mexicano? Sí, yo soy mexicano. No parece mexicano, you know. So, you know, it's what is a Mexicano again? So we can think and debate what is a Mexicano, what is a Veracruzano, and so this is just a complicated thing. So we began to start thinking about developing educational materials, as I mentioned, And we have this wonderful Your Heart, Your Life manual from the National Heart and Lung Institute that is now in the current, they have adapted it now again. It's a very exciting manual with a lot of videos and fotonovelas and things that we have utilized throughout the years. And one of the things that we have utilized is that we have utilized La Familia Ramirez. La Familia Ramirez team cuts across all the different interventions to work with La Familia Ramirez. As a matter of fact, the fotonovela that we developed with the hypertension was El Hermano. We built up, we make up an hermano from La Familia Ramirez, another brother, and so we end up doing a story about El Hermano so that we can, when we do a hypertension control, we can say it's the same family. Remember that fotonovela? What is the brother? Now we incorporate the brother. So that's kind of like the theme. And we have that fotonovela. If you want it, I would be happy to send it to you free of charges. And also you can take a look at the CDC website. So we gave that, and we selected the community through a process of training promotoras as the first element of empowerment. And we defined cultural strategies to build into different designs. So let me just show you the kinds of different designs. I think about the first, sort of like we believe that the first way that we were thinking of learning is the brokerage of community alliance development. That is really brokering with the community to start thinking about, in community-based participatory research, you always think about, okay, who are going to participate in our communities? How do we brokerage with people, not to say, well, you're going to come to my meeting and you're going to be the president, the vice president, and the director of this community alliance, and then that's it, goodbye, thank you very much. And then we end up being really very mechanic. So we, in one of the projects in North Texas, we didn't do that. We end up giving them sort of like, as you see right there, they were sort of like this, and this was just a thank you. So like that was our first meeting. We say, we thank you for coming to be our friends. We will know later what you're going to do with us, but we don't know now. So let's explore together. So they liked it because they say, oh, this is not really the president, vice president. It was just a little more laissez-faire to try to think through. So we had a 30, 40 number of alliances coming in that after 3 years now, probably because of sustainability issues, and I'm not there, and not because of me, and there's so many other issues that are about sustainability in North Texas, so they've been able to monitor a little bit, but not a lot, about what is that coalition that originally was established to set up a promotora model. So that was an important piece. But then I think one of the interesting issues about the trainer model, as I mentioned about the brokerage, you can have the possibility right there to start thinking about what are some of the process dimensions of culture that you can bring into different elements. And a lot of people think about culture as language and culture as being Mexicano. No, that is not culture necessarily. There's many dimensions of culture, many opportunities to begin to start thinking about. One of the interesting things that we did was in the Paulo Freire kind of empowerment methodology is to look at develop a promotora vision. And what we did, and I'm going to show you now, is how we create a vision for a program. Suppose that we have here everybody, and I put there just a blank place, and I allow every one of you to start putting together some of the vision. What is it in ways of a painting? So we developed that creativity of people to start thinking, what do you think, promotores, is your vision for your community? What are the things that you can do? So I'm going to show you how they created the vision. Then we can apply that in this context of recruitment, in interventions, in the examples of the models and the techniques that we use. So it could be all the way from the beginning of development to the end. So that means that you have to be there all the time, working with communities all the time. This is not an in and out. This is an in. We don't go out. We stay in. So I think that's been the problem. Sometimes we have been going in and out and in and out, and we have all kinds of writings and all kinds of things. And what happens, communities, nothing changes. So we need to start thinking about, hopefully there are new programs that have commitment, and you've seen one example just with Dr. McCormick, what they're doing. So this is the vision that we did. This is a promotora, 6, 7 years old, 70, something around that, young promotora. And this was, we created in North Texas when we built and asked the promotoras to kind of think about what they think. So they thought about, we have to take care of our hearts. So we have to really begin to start flowering or watering these flowers, because so if we bring information about heart health, it's going to be like the same way that we're watering the plants. So this is, and we have our family that we care for our family. So this is kind of the module that then we converted into nice posters, and this was the modus operandi of the promotoras. We gave them their name, we gave them their photo, and this was their vision. And we always work together in a democratic system where we all sat in a table and say, we're all together here to build that vision for communities. Sometimes this is difficult to measure. How do you measure whether you have your vision versus not vision? So a lot of those things are a little bit challenging to measure every single process that you do in interventions. And sometimes that's been the problem, because sometimes you say, well, this is really not very good science. I mean, working with this kind of stuff is not really good science, but I say it is a good science about working with communities. But we need to find out the way that we can integrate that into other kinds of questions. So the next is about the core elements of the manual that also can be in many ways building about competencies of risk behavior. This manual is science-based. It's from the National Heart and Lung Institute. It's a science-based manual that has a lot of elements that we then integrate with communities, that builds skills, that builds fun programs, that we also have worked with pledges. We pledge people to think about, what do you pledge today to begin before the intervention? What are the kinds of things that we pledge? And we are using that in the program that I'm going to show you. That. So basically, yes, a lot of the family, this is coming from the hypertension model. This is Doña Fela right here. This is Doña Fela that was born in 1994. She's still very young, and she's the mother, and this is their son. And so this is their other son. So we made up this son, and so this is based on behavioral theory, actually, on some behavioral theory that Dr. Berth, myself, Dr. Berth is one of our faculty members who helped us to bring up some theory components to it of self-efficacy and intentions and all these different kinds of things. Anyway, so this is the same. This is Doña Fela, the same Doña Fela that you saw before. So you see, and this is Mariano, the brother. So this guy is brother with this guy. They haven't met actually, but I think pretty soon they're gonna meet. They actually met a little bit when we did the hypertension study. They met and they actually like each other. So that was kind of nice to see. So that was very reinforcing. So, but then ultimately we say, okay, el trabajo, me despidieron, el trabajo, yo debo, la renta. My goodness, I mean, this is where sometimes it gets so chaotic that we cannot predict every single thing for communities. What we need to do is be there for themselves, for them, so that we can kind of start kind of following a progression. So that's how we think culture can be. We are learning how we believe maybe one mechanism to start thinking about community outreach. We believe is important. So now let me tell you a little bit about some of the models that we have presented. This model is the model from the HRSA project that actually is very much implemented in Centro San Vicente. But this is coming from a project in Laredo, Texas. And this is where the brokerage begins to see. You see the medical visit goes in, and there is an assessment. The education and verbal printed handouts take place. And then there's a treatment plan that then begins the referral program to the promotoras with group classes. And then there is a follow-up 1 month, and then there's a follow-up 3 months as needed. But this begins to start thinking, and so some of the clinics that have incorporated this method, and Centro San Vicente has incorporated this method, although it hasn't really been defined in this way, but it is really something that they begin to start building the medical model. And this is, again, remember, they might find this hemoglobin A1C really high, and all of a sudden say, well, you know, we need to really get you a treatment plan. But then we know that the medical they know that they have to link it to the promotora so they can begin to start looking at the way to start building up a rapport with the community. So we've seen the sample results where, yes, indeed, some of the average hemoglobin A1C begin to change. This is a very small sample, but you can. This is one example. We have done a little bit of an analysis, not only this clinic, but some of the other clinics where we have presented some of this data. Some of this data, again, is problematic in the sense that we cannot control. Sometimes the clinics don't have all the age range and all the things that we want to have for control variables. So this is important when we involve in clinical interface with communities. We need to involve evaluation interfaces with data and all these things so that we can make a story better. So, but again, this is a good attempt. Now I'm just going to move you into this phase of the Heart Phase project that we have done here for the last 4 years. This is an NIH project that we have with our colleagues This is building up on the Salud para su Corazón program that we've been working for many years. So we first came here, say, let's try to do one project where the only thing we haven't done is a randomized clinical trial. Let's try to do a randomized clinical trial to see what happens. So we began to do, this is a CBPR project to unite the community to work on together for reducing chronic diseases. It was funded, it's still funded by NIH the first 3 years. We got funded, now we have in the next 5 years, so we're in the first year of 5 years. We might have another 3 years to do sustainability. We're in the first year of that second, and I'm gonna show you we're in the hard 2 phase. This hard phase was the first 3 years where we tested a randomized community trial, and it was our partners, UTEP, School of Public Health, El Paso Community Project, and our wonderful friends from Centro San Vicente. The project addresses risk factors for leading chronic diseases, and it was really to build up a community health worker model as the anchor approach to go in working communities. So we develop information gathering, we establish a community advisory board, and we develop working with promotoras to strengthen the health and the contributions, and we carry out the intervention. Why El Paso? Well, I'm going to skip that one. You know why? The community health worker was a team of 14 members. I think at the beginning, our community-based participatory attempt was limited in some way. We didn't really gather a lot of momentum with them, but we're in the second phase. We hope that we gather more momentum with them. And this is kind of the logo. Remember the logo that I showed you about this? Well, this is the logo from the North Texas. Well, this is a similar, this is a logo about the family that we have. It's called Health Education Awareness Research Team. So that's the logo that we decided to build. And this is la visión de la promotora, es la visión de la comunidad, no? The vision of the promotora is the vision of the community. So this is the vision of HEART, is the vision of the participatory approach in El Paso. So what we did is the role of the community health workers was to serve as catalyst for action to deliver. The model was based on outreach for approximately 330. We used a randomized block design to try to go to a particular community that the community wanted for us to participate in the lower valley. So that was the way that they wanted. So we tried to develop their ideas and try to follow up with where the community, and then we try to use the science, to use randomization, to use block design so that we don't contaminate as much as possible, and we can try to do a 4-month intervention guided by the promotoras. The 4-month intervention, we knocked on almost 3,000 households. Again, we went to the community there, not in the clinic, but in the community of the Lower Valley, and then we brought them to the promotoras in the clinic San Vicente, and then the promotoras engaged in a 2-month intervention of Su Corazón Su Vida, which is Salud para Su Corazón program from NHLVI from Doña Fela. And we had 9 sessions with 2 promotoras. We're using a variety of teaching aids. And then we follow up with 2 months individualized teaching and counseling, which was really a phone contact and say, how are you doing, señora? The promotoras call them to see how are you doing with phone calls and sometimes meeting at Centro San Vicente. We had a randomized and the controls were received written information but not the intervention. So we had, for the first time of Salud para Su Corazón, able to collect laboratory work, lipid panel, glycosylated hemoglobin, glucose, weight, height, waist circumference, blood pressure, a lot of demographics and a lot of issues of behaviors, stages of change, beliefs about heart health, self-reported dietetic behaviors. And we find the same thing in the baseline as Dr. McCormick, as we have seen before. 51% of this is baseline data, family history of disease, 51% of the intervention group, and 45% of the control group reporting having a relative with cardiovascular disease. In both groups, 67% of the participants reporting having a relative with diabetes. More than 40% of participants in both groups used medication to control blood pressure. Nearly 30% used medication to reduce blood cholesterol, and 25% of the intervention and 25% of the control used medication to control diabetes. That just shows, and we don't know, we were not able to follow exactly that medication, but that just gives you an idea of some of the challenges that we have and the risk factors that we exist. This is about the nutrition, the overweight and central obesity. We know in both groups the mean body mass index was over 30, indicating a tendency towards obesity. The waist circumference in both groups was above 40 inches, indicating a tendency of participants accumulating fat in the abdomen. In both groups, no participant presented normal weight. And more than half of the participants when considered obese. In addition, 43% of participants in intervention, 49% had waist circumference above 40 inches. So we know that there is a lot of very similar work that they've done. And so metabolic syndrome, this is about an indicator. nearly half of the intervention group and 40 of the control had more than 3 risk factors for metabolic syndrome, and nearly 1/3 in control have reported diabetes. So that was what happens after we got the promotoras? Well, we got 4 months only, 2 months and 2 months. We collected data at the baseline, all this clinical, and we collected baseline afterwards. So we found, in a nutshell, that we looked at very consistent in terms of participants in intervention, and we controlled for baseline, and we did some more multivariate analysis to look for improvements. Basically, what we found is that participants in intervention reported a mean improvement. Constructs basically is the same as I mentioned before. So there were some statistically significant difference between some of the control and the intervention in terms of mean values, control for baseline, and some few confounders. So we find the same things. And then for the perception, we find the same things of efficacy. So that was very, very consistent that we found the pattern. We find very consistent in terms of the behavior. But now, with the clinical data, we didn't find significant differences. However, what is interesting is we find very important patterns of really changes between the experimental, and they might not be that big, but there's still some percentage change in LDL cholesterol and percentage change in total cholesterol. One can say, well, that's 5. Well, how much is 5? Well, I've just done look at a literature review to see how much changes have existed when you do interventions that are associated with one thing. They look at 14% to 90%. We have 5%, not significant. However, this shows that indeed they're going into the right direction. And this was actually a risk reduction for many factors, not only one factor. So we are moving in the right direction. So we say, well, now we can move into more environmentally kind of like now I don't think can go back to the community and tell them, knocking on the door and say, hello, how are you, Senora Ramirez? Could you go back? No, now we want to go to their community and we want to begin to start thinking about how to do now this environmental restructuring. That's what is kind of similar to Dr. McCormick, because what we said, well, let's start thinking about the YWCA. The YWCA has a very nice community center right there in the Lower Valley. Let's talk about parks and recreations. Let's invite him and let's tell him that we're going to place promotoras de salud in their settings so that we can launch a group of programs that are going to be called Mi Corazón, Mi Comunidad, My Heart and My Community, and we are going to emphasize physical components and environmental components that are right there in their community. We're going to really begin to develop with their partnership, and we're going to anchor already some programs that we have used, like Salud para su Corazón, in addition to all kinds of other programs. So what are all these programs? I'm going to show you. So the Heart 2, which is this level now, we have this goals to increase awareness of the programs, increase same behaviors. We cannot collect clinical data now because this is very expensive. We're trying to think about probably reaching 700 people for 3 years of intervention that we haven't begun. We are in the planning phase right now. And the idea is that we later on would like to sustain the promotora model. We want to show new organizations that indeed this system of community outreach can work. So this is what we embarking. We want to really begin to start intervening in the Lower Valley. We have an evaluation tool that is going to show case elements of evaluation for their own individuals, and I'll show you a little bit like that. We define, hopefully, promote policy. After 5 years, can we promote policies and tell them the people, like you mentioned that they already are integrating people, doctors in the city government. Can we do that? Can we really begin to start changing? And the idea that we can really do connections with community outreach, have FTEs then stabilized in said parks and recreations, have FTEs put in the YWCA, have FTEs in parks and recreation of Promotora, and that's when we begin to start connecting with restructuring, because sometimes we cannot change a lot of things right away, parks and all these things of physical elements, but we can begin to do something like that. So what would it be? So we have these partners. We kept the Centro San Vicente that is going to work with us. We're now going to start working more with the YWCA and we are going to work with the parks, and we go have a whole participatory approach to train all of us together into Public Health 101 and Promotoras de Salud, and we are going to have 4 Promotoras de Salud paid, Promotoras integrated here. We're almost ready to hire them so that they're going to be connecting with the YWCA, connecting with the Parks and Recreation to begin. And then what we're going to do is we're going to develop a health card. We're going to develop a fun health card so that each individual is going to have their own health card. And we're going to try to put in that health card some of the risk factors a little bit, but then we're going to try to do it like a very fun health card where they can begin to see, oh, I already went to that program, check me. I already went with that program. And look at my changes in weight, look at my changes in cholesterol. So they're going to be having their own passport of health. So 700 people we expect to have a passport of health so that we can begin to start thinking about whether they're beginning to go to the program. So what are the programs? There are Mi Salud como Mi Comunidad. There's a whole set of, we're going to concentrate on adults. So the idea now, we have a person now which is called a curriculum specialist who is now going to parks and recreations into YWCA to see what are some of the programs that are going to be associated with lifestyle nutrition. And can we do, and we're thinking of doing coffee chats for building nutrition. So we have our work on peers, things that coffee chats, they're going to chat about their things and peer support. We're also going to have coffee chats for exercise. Okay, what did you do? So we're going to have a lot of coffee chats. We're also going to have changes, perhaps cooking demonstrations and a grocery tour. We've done some before with the promotoras, so we're going to take the promotoras so that they go to families. And we're going to try to then do salsas, the same thing in parks and recreations. We are examining right now where in the parks and recreations we're going to set up all that. So this Mi Corazón, Mi Comunidad is going to be in the planning stage. We're going to try to put a menu of activities that people can begin, and we're going to rotate them every 6 months, meaning we're going to ask them to do 10 things from different elements. And so we're going to try to see, and we're going to try to follow this very carefully with promotoras and with our students, and to monitor how much of this Mi Corazón, Mi Comunidad everybody's doing. One interesting thing that we are doing is that the YWCA have a swept card. A swept card? A swept card. So every time somebody wants to go to a room, they sweep the card. So we're going to monitor how many times they go to that room. That room may have specific activities. We're going to offer, for example, Salud para su Corazón Module 1 every Monday and Friday. Then Module 2, Tuesdays and Thursdays. And so constantly we're going to have programs all the time, but we're going to have programs that are already in place, but also we're going to have programs that promotoras are going to do. And then we're going to try to use parks and recreations afternoon schools to tell the kids how exciting it is so that they can bring their parents to the program so that we can begin to start working with the kids we cannot afford to evaluate the kids right now for the funding, but we're going to try to concentrate on really beginning to start looking at for adults, what would it be the kind of restructuring that we can use that can really place that opportunity for people to begin to. So we are going to actually, one of the interesting things here is we're going to try to, the Y says, we might close this site because there's not a lot of people coming in. Can you guys help us? Can your promotoras can help us to bring people? Because I think maybe they don't go because probably they don't feel that this is part of their community. So we have a great opportunity to say, if we anchor and brokerage our community workers, can they begin to recruit them and make them feel comfortable to come to la salsa y el cha-cha-cha, y the next month is going to be rock and roll, y then, okay, vamos a hablar de la charla, how are you doing? And we're going to try to monitor that because they're going to have their health card, they're going to be monitoring what they did. So then we're going to see after 6 months, we're going to try to do evaluations in year 1, year 2, and year 3, and we unfortunately don't have the capacity to do clinical, the idea of the lab work, but we're going to do body mass index, we're going to do waist circumference and blood pressure. Plus, we're going to use the same questionnaire that we use in our other project, so we have the same baseline data to come. So I think this is the last one. This is sort of like if I think about the reflection of how I learn, how I've been, as you know, we are constantly learning about this, is how the building and culture into prevention research. In my own reflections and looking at what the communities really are engaging in community-based participatory and trying to really integrate them, is that expressions of culture must be many. Many dimensions must be captured of the cultural milieu of individuals, families, communities, and community system. Community mobilization can take the form of an outreach process that engages community people, promotoras, in the action of health promotion. Elements of culture must be captured in the form of a vision to set the stage. Translating acculturation, family cohesiveness can be done by promoting language, ethnic pride, social support, connecting with people through games, role modeling, symbolism, art, food, from this initial cultural expression, one can move forward to develop more complex models, more control of variables, more sophisticated interventions. But I say that the sophistication of communities is very high, and that we have to learn to be sophisticated enough and have enough dignity and being humble to learn how to learn to really begin to learn these processes and take our chances with, because sometimes we cannot publish this right away. These things take time. So we have to take the chances to bring up communities and still begin to start developing a community-based, evidence-based, but it really has to do with what we believe is, with this, the social justice to bring to our own communities the health and the opportunities that they deserve, so that the way that we have taken opportunities. Thank you. No questions? Good. Okay. Do you have any social? That is a wonderful question. Well, actually, not directly in this team right now. So we have, I think when the clinics have the multidisciplinary, for example, the clinic in Centro San Vicente and the clinic in Gateway, they all are a very exciting multidisciplinary team. One of the things that really has worked well is the fact that the physicians are really buy into it. And they meet constantly with the social workers, with the promotoras, in a way that all of them, and so they're trying to get reimbursement from CMS. Now we have a great opportunity, because for the first time the promotora actually has a name in the labor, is already put as a professional work. So that's something really, really important. So some people have taken, and some physicians, for example, have taken the opportunity to do the reimbursement by giving the opportunity for promotoras to get the work and then being reimbursed into the clinic, and then the doctor in la clínica gives back to the promotoras. So there is a way that we can begin, but I think social workers are really much because of the fact that depression and some of these things happen. I mean, we live in a situation where we're human beings, right? You remember that guy said no money. So it's like, if a guy is really have no money has been evicted tomorrow, and I come with a project tomorrow, you think that the person is going to like the project? No, he's thinking about being evicted. So he has to, or she has to react. So we may have to really work with our interdisciplinary team to understand how to address that issue. No? So somewhere there, somewhere. Did you? Okay, no. So we're. Sure.
One of the things that we ran into in terms of working with the community was one of perception. And this is where if there has to be a two-way street in terms of we have to learn from the community, but we also have to learn sometimes from, it goes both ways. And that was because of the levels of obesity in the community, and the fact that everybody had somebody in their family, if not themselves, who had diabetes. These were not seen as issues. So people, when we first started talking, they said, oh, our biggest problem is we have bad water. Or the biggest problem is we have these maquiladoras dumping waste into our river, and they're polluting us and causing all kinds of bad things. Yet here was the huge problem of it. And so there was a long dialogue and discussion about, and many times, particularly with our community advisory board, about the perception of illness and what this was about.
Oh, actually, this is wonderful, Joe. This is a great question, because I think that really is an example of how the dignity comes in a little bit. So like this exchange of having the opportunity to listen a little bit and perhaps begin to start building that rapport. Okay, for them, it's clear that they don't see obesity, but this is, why would they see it? Because this is their own, I'm putting my perspective into their perspective. So, but I think they should have that perspective, but they don't have that perspective. So now the question, we've run this all the time, but I think the idea is that as we begin to start working with the people and beginning to start looking at, okay, but let's start role modeling and begin to start using some games in symbolisms, we begin to start really seeing the people being connected. They really do want the best for their families, but sometimes it's very complicated. And I think is, what is it? Why X, Y, and Z, understanding why they do not see obesity as a problem. Well, it's very complicated because how can I know if I'm not in their shoes? I'm not really deprived from many things. I'm not depressed. I don't know what they see as issues. I have no idea, no clue. So the best idea is maybe I'd be more humble and try to think. And so I think you guys working with that approach of looking with the community base and working with the people, then I think we have anchored it into communities. That's where I believe that, I might be crazy, but I believe that the artistic expression in communities and the work that we can build on art and symbolism using based information, using evidence base is key, because I think when we begin to build artistic expression and we allow people to role model and they begin to forget about few things and they begin to integrate. But I think the prerequisite that you describe is that you're able to dialogue with the people. And I think, yeah, who is the community? No? Now we can say, who are the community? Are these people representing the community? I don't know, but that's something that we have to figure it out. Who are the community people? How do we, is this community-based organization represents the community in what way? So I think that that dialogue of being there constantly and being able to be functioning in some way to understand this complexity of issues is something that I believe is exciting. I think I invite you to read David Buchanan's work on the philosophy of in health behavior about and Dr. Insan and some other people that in the past have looked at about what are some of the priorities that I would say if I were to put priorities. What would be the things that I would put in things that are important for people? And it's kind of interesting because none of these things come in obesity, and it comes about, do I care? But an interesting thing comes about, would I feel a little bit uncomfortable if I come here and I'm a little overweight? Would I feel uncomfortable with you? See, that's the kind of question that they will feel. So maybe that's asking a different question. Would I feel uncomfortable? So I'm not talking about you're overweight. I feel uncomfortable. Why would you feel uncomfortable? So and that would say, well, do we need to have everybody just a one-to-one? Well, you know, if we could have community outreach brokers all over our communities, if we can have social workers very much working constantly in communities to deliver the best, to listen and see how we can best launch your interventions, I think we'll be in a better shape. It's complicated, but...
Let me say one other thing for science. I think that, and I'll pick up on what you said about being there all the time. Our community, at least before our school was there, really didn't have any experience. They had experience with researchers, but they were from somewhere else. Came in, did study, maybe it took blood, maybe it didn't. Nobody ever heard from them again. And I think in our experience now, being able to conduct, explain what we're doing, and then go back and show them the facts.
Exactly.
Here's what we found.
Exactly.
Here's what's in the community. Now, you know, what do you think we should do? Do you think this is a problem? What do you think we should do? It plays a big role. And this is why I believe that having public health in a community that really can do community-based work there, but science, and then feed it back to the community, is turning out to be quite useful.
Actually, that's wonderful. I think that's exactly right. I think that, but sometimes I think sometimes it's not like a null sum of everything. Sometimes science is going to be there. Sometimes community things are going to be there that are not necessarily interrelated at every single time. And so I think we have to kind of learn how to blend some of these needs for understanding science, for applying science, translating science, and how do we learn about communities into the way that they are, because communities are very complex systems, extremely complex systems, really. If you think about communities and individuals, very complicated. We are as humans so very complicated, and we have to have the capacity to understand that complexity. So I think that's where these ideas of complex models of, like Resnick mentioned about chaotic systems and system thinking and all these things are science-based approaches, but are challenging approaches because that has some multi-level factors with so many things. But I think the important thing is not to stop and say, I did a meta-analysis and this is what I show and that's it. I'm going to now be happy and tell the community, this is what we found in our meta. I think that's only one way of applying, but it's not sufficient. But that doesn't mean it's not good. It's not good, but it's not. Is that a necessary condition? Well, we can debate that. Is that a necessary or sufficient condition? But I think those are the kinds of questions that we as researchers, I think, have to question so that we can then begin to integrate better into ways that makes more sense to communities. Oh, would you guys want to answer that? How are the promotoras? Do you guys want to talk? No, I didn't mean to put you on the spot, but Lorraine, would you like to say something about the question? How the promotoras are viewed in the clinical? Can they take the information? How much rapport exists between the promotoras and the medical system? And in your view, how is that? Thanks, Lorraine. I didn't mean to put you on the spot, but I thought, well, what about asking the promotoras? And then the second question is a very exciting question. I was recently in Mexico City presenting this work, and all of a sudden one physician came and attacked me really hard. Said, boy, you are doing a disservice to medicine. How these promotoras can really take this is very dangerous to our communities, how they're going to, and I say, I very humbly say, well, you know, this is the problem, that I think they're not really there to be physicians, and they never weren't going to be physicians. Your job is very important, but this is another job. This is a job that I think is very legitimate to exist. The mean that you don't legitimize, that doesn't mean that the community doesn't legitimize. And as a matter of fact, the promotoras are going to be doing many important functions that can work with the diabetes educator. Doesn't mean that they have to replace the diabetes educator, because that was the whole thing. Oh no, now promotoras. Oh no, they're not diabetes educators, they're not health promoters. But I think, Lorraine is a health promoter, and she can feel that she works very well with promotoras because they know that they are a team, that everyone has this. This is all about, not me, it's about the community here. So I think that, when you have a system that really understands the complexity of what is delivering culturally competent services, will acknowledge that this is about integrating diabetes educators and integrating social workers and integrating medical doctors. And this is not about the medical doctor being the one that is the god, and the other one, the promotora, is the peon. This is about everybody being in conjunction with the desire to bring about change. Doesn't mean that I don't respect doctors. I do respect doctors. I have a lot of respect for doctors, but I think that in our system sometimes that has been the case. Where if I just I remember when I was in Mexico City, I was doing my bachelor's degree in a clinical setting looking at severe malnutrition. Every time I was doing my bachelor's, right? Every time I put the white coat, my goodness, el Doctor Balcazar. You know, that was my good. They changed so much. The nurses, oh, doctor, ¿cómo está usted? And, you know, it's just like, oh my God, I'm the same person, but just without. So, I mean, it was just, and this is really hard. And this is a system that is very difficult to break, el doctorcito, no? So that's something really hard to break. No, we have, but I mean, a lot of times the men, hay promotores de salud. Menos, pero hay.
Ethical context, considered to be perhaps inappropriate
No, no.
the position of the physician in Mexico saying you shouldn't do it, but if you leave it only to the individual talent of the promotor to handle those things, then it will be a recipe for trouble later on. So how is it that that's handled? The ethics of it and the confidentiality of it?
Well, I think that in my experience of 15 years and 20 years working with promotoras, I've yet to see a case where the promotoras are being sued because they did something really or not. I think that this is a good question, but I think that it is amazing. One time I was in Chile, there were all these medical doctors and doctors of their directors of health clinics. And all of a sudden, there's Esperanza Vázquez from Centro Salud, and they had to talk to all the medical doctors. And she came and said, "Doctores, con todo respeto, I cannot be like you." After 20 minutes, all the doctors were like, "My goodness, Esperanza, you are wonderful." So it took them 10 minutes to understand what she was talking about. She was talking with the command of understanding what she knew and what she didn't know. So that brings up to the question of training. We cannot just think that promotoras de salud are going to be somebody in the street coming in and is promotora de salud. No, 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 no. Not everybody is going to be promotora de salud in our communities. That's a fallacy and a mistake to think. And also promotoras de salud, there are leaders, there's some promotoras that are advocates, there's a wide range of, like, physicians are dermatologists and physicians are all kinds of professions. The same thing with promotoras, and not all are the same. But the one common thing that we have believed is that there's got to be good training. There's good training on what can they do and what can they not do, and follow the training with evidence-based science that says that this is hypertension, this is hypertension, and you do not deviate from that. If there is any question about the medical, say, I'm not a doctor, please. And that's what I think Lorraine was mentioning. A lot of the times, then they go back to the doctor, but the doctor say, then it's kind of interesting because they ask Esperanza, what do you think this and that? So they begin to trust the promotora because they understand that in that conversation, this may exist. So there's a lot of ethical elements of respect about confidentiality and about things that really are associated with training and with following and monitoring the promotoras. I think it's unfair to believe that if you train promotoras and they're going to be goddess, right? Or that they're going to, okay, that's it. Es una comunidad promotores, like the same thing as speaking Spanish. That's good projects. I mean, that's the same thing as a promotora just bringing up from the community and having no training. No? You kind of really step up and do training and do all kinds of things for the promotoras and constantly being retraining and training and constantly has this interdisciplinary. And I think we're out. Well, just one more. Yes, exactly. Not very much so. I mean, in that the good systems of care, we see that everybody's involved and that everybody talks, and that would be a wonderful interdisciplinary approach. That I think there are some already models there that show that indeed everybody has its place. So now I think I wanted to ask Dr. Anders to come and wrap it up for us.